morning or good evening to many of you who are joining us from Africa. Thank you so much for being here on a Saturday. So, I'm excited to share with you what I have learned about prostate cancer in the last 6 years that I have been doing this. I think I know far more about prostate cancer than I ever thought I needed to know. And my goal is to hope to give you information that you can use in your practice. So, we have a lot to cover today, so let's get started. So this is just a quick outline of what we're going to cover today. Again, my goal is for you to walk away with some basic understanding of what prostate cancer is and some practical tips and tricks to use. So this is going to be much more about understanding like the how and the why rather than just strict memorization. All right, a little bit about just the basics of prostate cancer, essentially the anatomy and some terms that you may come across that you need to know. We're not going to review this in great detail, so just some of the basic facts of prostate cancer. So I found this great little flyer from the Cancer Association of South Africa that has a good overview of prostate cancer. As many of prostate cancer is the most common cancer in males other than skin cancers. You probably see this in your clinic where a good chunk of your population are males with prostate cancer. So the current statistic, it's about 1 in 8 men will be diagnosed in their lifetime. There is a bit of a higher rate in those with African ancestry. But the good news is that prostate cancer is highly treatable, especially if it's caught early, and the prognosis is good. So oftentimes men will actually die with prostate cancer rather than from it. Prostate cancer typically doesn't have any signs, especially when it's early. So it's usually diagnosed or the first sign that something is wrong is that they have an elevated PSA. And so that's what starts their whole journey. Let's start by just reviewing basic anatomy. So, what is a prostate? I'm actually surprised that there are men that we are treating who actually don't really know what their prostate does or what it's for. So, this is just a small walnut sized gland. It's part of the male reproductive system, and its main job is to produce that seminal fluid for ejaculation. The semen's produced in the testes, and the seminal fluid comes from the prostate. The prostate, its activity and its growth is stimulated primarily by testosterone. And so that's that hormone primarily produced in the testicles. And then the prostate itself, it will kick out a protein called a proton specific antigen, known as a PSA. So that's a term that you probably hear a lot. And your prostate cells will produce this PSA. It's just that prostate cancer cells produce it at a higher rate. So when you start to see it climb, that's where you get concerned that there is something wrong. So again, that prostate is that little walnut gland that sits in between, like right underneath that bladder, and then the rectum is sandwiched in between those two organs. And then you have that urethra that's running right through the prostate that drains the urine from the bladder. So having a good understanding of the anatomy helps you understand when they're having symptoms. So we'll quickly talk about grades and stages. Grading prostate cancer, you're going to hear about the Gleason score. That is very commonly or pretty much how prostate cancer is always graded. And what this is when the pathologist is looking at the tumor cells from the prostate cancer under a microscope, they're basically looking to see how closely do those cells still look like a normal prostate cell. And the less it looks like a normal cell, the more aggressive it is. And then the higher the Gleason score becomes. So what they do is they're looking at all of the cells under the slide and they pick out the pattern that is the most common, and that's your first number. And then they take the second most common pattern, and that's your second number, and they add them together to get a Gleason score. And it's important to note that like a Gleason of 3 plus 4 equals 7 is not the same as a 4 plus 3 equals 7, because the 4 plus 3 is saying that there are more of the Gleason 4 in in their pathology. And so a 4 plus 3 is more aggressive than a 3 plus 4. And then as far as staging goes, so staging uses your standard solid organ, the TNM. So how much of the prostate's involved in the tumor? Are there any lymph nodes that are involved? And has it spread outside of the prostate? So you're going to take these three things, so that the PSA, the Gleason score, and that TNM score, and you're going to take all of those three and then figure out what risk category they fall into. So the NCCN guidelines, they have 6 different classifications for prostate cancer ranging from very low to very high. And so the reason it matters which category they fall in is because this is what's going to determine what treatment options they have. So let's talk about treatment options. The first question that you have to ask is, do you actually need to treat it? And the answer is not always. So, with certain prostate cancers, particularly like low risk prostate cancer, you don't have to treat it. You can sometimes just get away with watching it closely, called active surveillance or watchful waiting, where you might just be checking that PSA, maybe doing another image or biopsy at certain times to see if it becomes more aggressive over time. But if it doesn't change, then you just continue to watch it. Anything above low risk typically needs to have treatment. And so then you start to take into consideration how old they are. Is their life expectancy going to be greater than 10 years? Are they healthy? Do they have heart disease, diabetes, those types of things? And then cost and logistics also play a role. Some of these prostate radiation treatments can be up to 44 days of treatment. And if you don't live close to a radiation oncology center, that might be a deterrent. One thing I'll note is that surgery tends to be a young guy's game. So usually it's their cancer's not as aggressive and they're pretty healthy. So they can undergo a surgical procedure. And because their recovery tends to be a little easier if you're young and healthy. What we see in our clinic with radiation, those tend to be the guys who are older in their 80s or sometimes 90s or late 70s, and they tend to have other health conditions like heart, diabetes, those types of things, and their cancers tend to be a little bit more aggressive. There are alternative therapies such as like cryotherapy, HIFU, those types of things. They do tend to be more for lower risk type of cancers, and we won't cover those today. Oh, now my slide's stuck. Oh, there we go. All right, so let's talk about radiation options. Like I said, the knowing their risk category is helpful because this is what determines their treatment course. And so I put a link on the bottom here for the NCCN guidelines that kind of give you all the nuances and all the different options that they could choose. But I put this table together here that shows a little bit more of what's typical or what's common to see for the different options. So, as far as radiation options, you can do stereotactic body radiotherapy or SBRT. This is where you're giving like a high dose of radiation in just a few fractions, typically about 4 to 7. And this can be a great option for your low risk or favorable intermediate. Hyperfractionated, so this tends to be about 20 to 28 fractions and can usually is just treating the prostate, maybe and the seminal vesicles. And this is good for favorable and sometimes unfavorable intermediate. Then you have your conventional fractionation. So this is that longer course, somewhere about 37 to 44 fractions. Oftentimes, they're also giving some radiation to the entire pelvis to cover the lymph nodes in the pelvic region. You also can do some combination of radiotherapy with brachytherapy. So that's an option. And then the other type of radiation is adjuvant or salvage. And so this is for those guys who have already had their prostate removed. And now, for whatever reason, now they need to have radiation to that prostate fossa or where that prostate used to sit. And this can often be either they didn't get it all at surgery, or maybe they had a recurrence months or years down the road, and now you're treating that area. You can also do SBRT to metastatic sites. So if they have a small lesion in a lymph node or a bone, you can treat those with radiation as well. Another thing that is a treatment option is androgen deprivation therapy or ADT. So this is medications that you can use in combination with treatment, and we're going to cover that a little bit later on in the lecture.
Sarah,
So brachytherapy, sure.
oh, can I comment a little bit? Just like a quick comment on a previous slide, if that's
Yes.
okay. Okay.
Yeah, do you
Great.
want me to go back here?
Oh yeah, if you don't mind. Yeah. So I agree with what Sarah said. This, in terms of treatment regimens, is constantly evolving. I think nowadays for favorable intermediate, all risk, localized risk groups, including low, intermediate, and high risk, hypofractionated radiation is a standard, and SBRT as well. You can use like 20 to 28 treatment for high risk patients. You can use SBRT for high risk patients as well. Conventional fractionated, of course, you can use that for everything. In terms of brachy boost, you typically use that for high risk and sometimes unfavorable intermediate risk. But for favorable intermediate risk and low risk, you can use HDR alone. And even nowadays, some people are using brachy alone for unfavorable intermediate risk as well. The treatment paradigm is certainly evolving, and the field is moving towards more hypofractionation. This means fewer number of treatments, and that's for patients' convenience. Yeah, thanks.
Yeah, no problem. Okay, great. All right, so brachytherapy, we're not going to go into this a whole lot because I believe next week's lecture covers brachytherapy. But with prostate radiation, you have two different types of brachytherapy. So you have your low dose rate, which is permanent. This is where the radiation oncologist will go in and place these little radioactive seeds or pellets within the prostate, and they stay radioactive for a certain period of time, and then they lose their radioactivity, but the seeds themselves stay permanently in the prostate. High dose radiation brachytherapy or high dose rate, this is temporary. This is where they're putting needles into the prostate and then inserting a radioactive source that kind of sits there for a bit and then it's all removed. So like I said, I'm sure they're going to talk more about it in next week's lecture. So the next thing, once they know what radiation course they're going to get, the other thing that matters is how the plan is made. And obviously, this isn't something that the patient really has a choice. It depends on your center and what capabilities you have. But essentially, the way the plan is made is going to play a huge role in how much side effects that they will get. And this just has to do with how tight can they get those beams around the prostate and minimize the healthy tissue surrounding it from getting radiation. Like I said, the reason it's important to know this as a nurse is because one, it's going to help you anticipate side effect timeline. So, for example, if they're doing SBRT, you're going to anticipate that their side effects aren't really going to show up during that course. It's going to come after they're done. Otherwise, like the hypofractionated tends to be a little bit more of a hot and fast burn versus your conventional fraction is a little bit of a slower burn. So that just means that they might be having sometimes a higher degree of symptoms earlier on in treatment. And then as far as degree of toxicity, again, that comes down to that plan, right? How much of their healthy tissue surrounding the prostate is getting radiated. If the bowel and the bladder are getting more radiation, then you anticipate seeing more side effects. All right, so we come to our first poll question. So this is me just very curious how you guys practice in your clinics and what's the most common fractionation that you see in your practice. So the conventional fraction, hypofractionated SBRT, adjuvant salvage, or I'm not sure.
Okay, so it looks like most people chose hypofractionation. That's about 50%, half the patients chose that. That's followed by conventional fractionated, 17%, SBRT, 15%, and all others are a little less. Yeah, interesting. I think Ben Lee also mentioned in the chat that side effects related to the quality of the plan. Yeah, that's very true. Depends on the physician. A lot of times, not just the physician, but also the dosimetrist, right? Because we rely on dosimetrists to make a good plan. We do the contouring and everything, but the experienced dosimetrist will know where to avoid the hot spots, how to shape the beam so it's avoiding the rectum and the bladder neck. So I think that's a hugely important point to stress. Another thing I think is often overlooked and also we don't really know for sure is genetics. Personally, I believe a lot of times certain patients have a genetic disposition to higher toxicity. Actually, there is a test called Prostox, Prostox. Is a microRNA binding site based test. So patients get a cheek swab. It's a genetic test. That test has been shown to be able to predict long-term genital urinary tract toxicity if patients are doing SBRT. So, for example, in our clinic, we routinely give patients who are candidates for SBRT that test. About 10% of patients will return a high-risk score. That means they are really at elevated risk of developing late grade 2 or higher genital urinary toxicity. And in that case, we advise patients not to do SBRT because they're more susceptible or they're more sensitive to this high dose per treatment type of regimen. So we ask them to do slower, for example, hypofractionation 2028 or conventional fractionation. So I personally believe genetics is also very important. And we're just scratching the surface of that. Hopefully in the coming years, we'll have a much better understanding of that. But anyways.
Okay, thank you for that information. All right, let's move on, and we are going to talk about how to prep for radiation. Oh, I'm gonna get rid of that screen. All right, so let's see if I can get my computer to work. All right, there we go. Prostate radiation. When you're doing the CT scan and for every single day of radiation, they need to do a prep. And so these are not the guys that can just, just show up and get their radiation. They have a little homework to do. And it's really important that they get their CT prep correct because that's what the plan is based off of. And then when they show up for daily radiation, they're trying to match what their anatomy looked like at that CT scan. So they need to have a full bladder and an empty rectum. And it's really important if you understand why, then you can help teach the patient why and get their buy-in. So if you look at the screen here, so when you have a comfortably full bladder, one, it pushes the small bowels up and out of the treatment field because the small bowels don't love radiation. They're a little bit more sensitive to it. And then when your bladder is full as well, then as you see, less of the bladder is radiated. And then with the empty rectum, if you can get it fairly flat, then it's going to pull away from that prostate and less of it's going to get radiated. And the whole point is the less you radiate healthy tissue, the less side effects that you're going to get. How to prep for your CT sim and radiation. Off the bat, I'm just going to say practices vary widely from clinic to clinic. So I put an example of what some instructions on how to tell a patient to get their bladder full here on the left side and how to empty their rectum. I would say I see the greatest variation in instructions on how to empty the rectum for their CT scan or for treatment. Some clinics go very aggressive in getting that prepped, and some of them do nothing. So like I said, it varies a lot. But the key points is that when it comes to the bladder prep, the key word is comfortably full. Okay. So you don't want them to overdo it and have this overly full bladder at their CT sim, because if it's too full, then one, they're going to have a hard time matching that every single day of treatment, especially as they get further into treatment. And then the second thing is that if it's overly full, then that bladder ends up pushing and distorting the shape of the prostate. So that doesn't work either. A full bladder is considered to be about 250 to 300 milliliters on average. And it's important to tell the guys the more you stay hydrated throughout the day, the easier it is that they're going to be able to do their bladder prep. If they don't drink a whole lot of water except for their bladder prep, their body's just going to hold on to that fluid and soak it up because urine is waste. Okay. And then the other thing for bowels. So oftentimes we found that if somebody has like regular bowel movements every day, they're having a nice normal bowel movement, typically they don't require any intervention, but it can vary. So before we get into how to instruct them on getting that prep good and triaging when they're having issues, I'm curious how you guys do the bowel prep, just because, like I said, practices vary. In your current practice, do you use enemas to empty the rectum for their CT sim, for daily radiation, both, or none?
Okay. I think 70% people responded. It looks like half the participate participants said CT simulation, 28% says both, 21% says none, and only 3% says daily radiation. Sarah, maybe you can talk a little bit about your practice, and Sunshine, feel free to chime in as well. For you guys, I'll talk a little bit about the practice used in my clinic.
Yeah, so here in our practice, we're a little bit more aggressive when it comes to their CT stimulation for intact prostates only. So that means they still have their prostate. We will actually have them do clear liquids the day before, an enema the night before, and an enema the 2 hours before their CT scans. But then when it comes to daily radiation, then we don't do anything. And normally it works out just fine to do it that way. But prostate beds, we don't have them do a bowel prep at all for sim or for treatment. Sunshine, I didn't know if you wanted to chime in.
Apologies. We do bowel prep in the clinic for both T simulation as well as for daily treatment. Typically, it's based on what the patterns are of the patient, but we do have a couple providers who have protocols that they use. And we try to stay away from like daily enema use because that can be very triggering for patients and they can end up relying on it. Plus, it's not the most healthy thing to do. But oftentimes we're asking them just to watch the fiber in their diet, maybe use a stool softener, make sure they're having good fluid output. And then if they have trouble, they'll talk with our providers and work out a plan to help with that.
Yeah, great. Also, for the participants, Sunshine is a nurse at the Fred Hutch as well. I would say we use CT enema for CT simulation. I don't think we use that for daily radiation unless it's SBRT. Because for conventional fractionated and hypofractionation, you have 4 to 8 weeks of daily treatment. We would not ask patients to do daily enema for those treatments. That will be too much. And also, like Sunshine says, we typically try to avoid having like everyday enema. That's not a good solution. But in my practice, and I think that's a practice for a lot of other institutions, for SBRT, the 5 treatment type of SBRT, we do ask patients to do daily enema. I think that's quite important because you are giving a large dose per day and you only have 5 chances to get it right. It's important to have optimal anatomy every time. And only 5 times, I don't think that's a huge burden on the patients. But I agree for longer course of radiation, we only use that for CT simulation and not during daily treatment. And I always tell my patients it's important to have daily bowel movements during those longer course of radiation, even if they're not using enema. And we do cone beam CT every day to verify bladder filling and empty rectum. Thanks.
Okay, so let's talk about when they have less than an ideal prep. And so first let's talk about bladder. So if they're having an issue getting their bladder appropriately full, or if they're concerned even before they get to their CT sim, the first thing that I have them do is practice. So go practice at home. And the way this works is I tell them go to the bathroom, empty your bladder. As soon as you're out of the bathroom, drink about 500 milliliters of water, then set a timer and see how long it takes for you to feel like you need to pee. And we're aiming for that. Like, I could pee, but I'm not like so full that I can't hold it. And then at that point, they're going to note how long it took. And then they're going to pee into something that is can measure volume. And their goal is to be about 250 to 300 milliliters. So if they do this in practice and do it a few times and figure out how long it takes them and how much water they need to drink, then they're going to feel a little bit more confident on getting it right for their CT sim or for treatment. The caveat, obviously, this isn't going to work for somebody who has urinary retention where they may be not emptying their bladder all the way. So some guys, they just always have 100 or 150 mils of urine in their bladder because they don't empty it. And then you have to get creative. The other thing is to remind the guys, small variations from day to day is fine. If their bladder volume is like 110% one day, 80% another day, 70%, it all works out in the end. Not a big deal when they're doing those longer courses, not SBRT. The issue is if they're more consistently like 50% or less, then the nurse is going to get involved and help triage that. If they're having issues, look at their medication list. A lot of these guys are on diuretics because they have heart issues. And so that's an easy one. Just have them not take it right before treatment. So either take it really early in the morning so they're done by the time that they're doing their bladder prep, or just wait until after they get their radiation and then take their diuretic. The other thing is that they might need to avoid those bladder irritants. So if they're a morning patient, they might need to skip their cup of coffee in the morning because that's going to just cause a bit more urgency and where they're going to have a harder time holding that bladder. As they get through treatment, their symptoms are going to increase, making it a little bit harder to manage their symptoms. And so you need to make sure that you're managing those symptoms. And then, as a last resort, some clinics have penile clamps. And this is what a penile clamp looks like. It's a little foam clamp that, after they have emptied their bladder and drank their water, they would apply the penile clamp to the shaft of their penis and leave it on until after they have had their radiation treatment. I will say this is not common. I think I've had to use it maybe 2 or 3 times in the 6 years that I've been doing this. So, what if the issue is stool? If the rectum is full of stool and they can't get treatment? So the first thing I always do, go talk to the radiation therapist, go talk to the doctor, have them look at the films, and that can give you some information. And also ask them, is this a one off? Are they having a bad day? If they're having a bad day, then you probably don't need to do anything about it. Just see what happens the next day. But if it's a pattern where their symptoms just always, they're always coming in and and I say usually like 2, maybe 3 days in a row that you're having issues, then you're going to intervene. And you're going to start by just sitting the patient down and talk to them. Get some information on what is their baseline stool pattern. Okay. What are they eating? People who have a high fiber diet, and I found that vegans, they tend to have a high stool burden. So even if they're having daily bowel movements, they just don't clear out because they just have a lot of stool. So that can be an issue. And then the other thing is look at medications. Are there things on their medication list that are either slowing their gut down or drying them out? Those types of things. As far as what do you do? For those people who are constipated or they don't have bowel movements every single day, diet options, quick acting diet options are things like prunes. So they can just try eating some prunes or some kiwis with the skin, and that can often help kickstart and get a bowel movement moving. The other thing is we will very commonly use a gentle plant-based laxative called senna. So we just will put them on that and then they'll stay on it daily through treatment unless they start having bowel issues and then we pull them back off of it. If there's somebody who has that high stool burn, so maybe they're having bowel movements every day, it's just they're not clearing out, sometimes we need to do a gut reset. And what this looks like is we'll have them go home and take a one-time dose of some type of magnesium laxate, something like magnesium citrate, milk of magnesium, something that's going to make them empty out their colon, right? So they're going to poop a lot, they're going to get all of that out, and then they're going to start some daily sauna to help keep things regular. And then the other thing is often, if, like I said, if they're high fiber or vegans, we might have to switch up their diet and have them reduce the amount of soluble fiber that they're eating. But if they need to have an empty rectum right this minute, right, and you can't wait around, an enema is your guarantee of getting that rectum empty. So sometimes that's just the best option for in the moment, but that's not necessarily a long-term solution. And then with gas, so same thing, air can displace the rectum and push it into the treatment field just like stool can. And that can be an issue as well. And again, this one definitely you want to know, is this a one-off or is this a pattern? One-offs, we just wait to see the next day what it looks like. But if it is a pattern, ask them like, what's their diet? Are they having diarrhea? Diarrhea, your gut is moving so fast, it is just creating excess air. Are they skipping meals? Are they smokers? Those types of things. And then as far as what do you do, the first thing is trying to eliminate those foods that cause a bunch of gas, and we'll go over those foods in the next slide. The other thing that you want to do, have them reduce the swallowed air. Okay. So things like straws, sipping a lot of like hot or cold fluids, chewing gum, things like that. The other thing is that they should be chewing their food really well and then with their mouth closed. So no talking while they're eating, that can help. Another good easy tip is that when they're starting their bladder prep, have them sit down on the toilet and just try and expel any gas at that point. 'Cause that can sometimes help as well. Walking is great for keeping gas moving through and keeping your gut moving. So after they eat, have them do a 5-10 minute walk. And then other times I'll have guys come to the clinic about 15 minutes before their treatment and they just walk some laps before they get treatment. The other thing is gas X, Beano, those types of things can be very helpful in reducing that gas formation. And then the other thing that a little bit as a last resort, but radiation therapists, if you have this capability in your clinic, they can just insert a rectal tube. And so there's a picture here of what that looks like. It looks like a Foley catheter. And to be honest, some clinics just use a Foley catheter where the therapist will actually just insert that into the rectum to try and release that little pocket of gas that's stuck at the bottom there. All right, bowel
Oh, sorry,
gas. The
just,
food, the
Also, just to chime in for a second. So the gas X,
Yeah.
yeah, we often do ask patients to take it if they have lots of gas. But a lot of patients think it's actually after taking gas X, I won't have any gas. So that's not the case. So gas X is just a surfactant. It's help pass the gas a little easier, but it doesn't really reduce the formation of gas. So they still need to address the root causes of the gas issues, like the diet changes, but it only makes passing the gas easier. And a lot of times I feel like in patients, it's a hit or miss. Sometimes it doesn't work. Gas X.
Yeah. Yeah. Yeah, so I would say just throwing on simethicone often or Gas-X is not helpful enough. And so this is where food definitely like those diet and behavior changes play a huge role. So a lot of times they do need to make some diet changes. These are the common foods that can cause that excess bowel gas. And I always tell people this isn't necessarily that you feel like you're passing a lot of gas, right? So sometimes they're like, I'm not gassy. And it's, yeah, I know that's because it's trapped in your gut and that's what's causing the problem. But yeah, we won't go over these in details, but just so you know, like the cruciferous vegetables, this just means like your Brussels sprouts, broccoli, cabbage, cauliflower, asparagus. The fruits that tend to be a problem are like your apples, peaches, pears, prunes. And the other thing to know is everybody's body responds a little bit differently. So it can be a little bit of a trial and error. The one here that we see that catches people off guard that they don't think of is carbonated beverages, specifically seltzer waters. If they're drinking a lot of just carbonated water, that also is causing an issue and is easy one to stop. All right, this is our first kind of knowledge checks. The reason that we treat with a full bladder is because one, it pushes the small bowels out of the treatment field. Two, less of the bladder gets radiated, or three, both A and B.
And while we're here, I think also just want to say we definitely aim for a full bladder. I think that's the goal. Often because of various reasons, patients may not have a really full bladder, but in actuality, at least I think there's some evidence showing that full bladder may not be very crucial in terms of avoiding radiation side effects. There's some studies showing that even half full or empty bladder in terms of GU side effects is not that different than a full bladder. It's just because the anatomy that's responsive or responsible for GU toxicity is pretty complex. There's urethra, there's bladder neck, there's trigone, and I don't think we understand it very well. If the patient can't have full bladder, that's great. But if they cannot maintain full bladder because of incontinence issues, I don't think it's very crucial to really go themselves trying to get a bladder full. Okay, I think about some 65 participants answered and that. So it looks like 70% participants says both A and B. And so it is the correct answer. And A and yeah, so it's both for pushing the small bowel out of the field and also to have less of the bladder get radiation in terms of percentage of the bladder receiving radiation.
Yeah. Perfect. All right. Great. Let's move on to talking about acute side effects. Acute side effects from radiation. Remember, these are the symptoms that happen during radiation treatment and then within that first 3 months. Chronic side effects, those are the ones that pop up after 3 months or often months to years later. And we'll talk about those in a different section. Just to know, the side effects from prostate radiation are very similar to the gyne side effects that was covered in the last side effects with a little bit different nuances. So we'll talk first about acute side effects and radiation as a whole. Remember, radiation side effects are local. So if you go back to that anatomy and what's sitting next to that prostate, it's that bowel and bladder. So that's primarily where we see symptoms. Radiation side effects are delayed, so it's typically midway through treatment, except SBRT, before you start to notice anything, and they gradually build and they get worse. They peak right around the end of treatment, maybe that week after. And then, as a general rule, most of their symptoms are gone by that 1 month mark. I usually tell guys about 70 to 90%, and then that 10 to 30% usually take a few more months, about 3 to 4 months, before they are either back to normal or at their new baseline. Maybe they don't ever fully recover. And then I put a link here for the CTCAE, just so you know, like what the grading scale looks like for documentation. Some people use that as a way of documenting. I typically will get a little bit more nuanced than just using a gradings. We'll talk about that next. Urinary is number one. So this is the primary side effect that you're going to be checking in with your patients every week while they're on treatment. It's really important to know what their baseline is. So most of the guys will have filled out some type of questionnaire at consult or something like that where they have a baseline read, because your doc's going to want to know what their symptoms are, what their urinary function is, because that actually will help dictate what type of treatment that they will get as well. If they have a really poor urinary function, they're less likely to get SBRT, those types of things. The other thing that you want to know is, are they already on any bladder medications? Are they on Flomax or oxybutynin and those types of things? And do they have a history of a TERP or some type of urologic procedures? Those kind of all influence how you manage patients on treatment. So when you are checking in with them every week, it's always good to ask the same questions every single time. How often are you getting up at night? How frequently are you peeing during the day? Is it urgent when you pee? Is it burning or hurting when you pee? Is your stream getting weaker? Are you pushing? Are you straining? Do you see any blood? Those types of things. And if you ask them that every single week, then you have something to compare to see how their symptoms are developing over time. And then the other key thing is that you're only treating symptoms if they're bothersome. Okay. So everybody's tolerability is different. Some guys, they'll get up 3 times at night, they go right back to sleep, no big deal. They're not worried about it. Other people, 3 times at night, they're miserable and they're asking, how can you help? This can't continue. Urinary symptoms tend to fall in two different buckets of symptoms. So you have your irritative and you have your obstructive symptoms. So with the irritative symptoms, I always tell people, think bladder, okay, and think inflammation. So what's happening is that, like, the bladder's getting radiated, particularly the bladder neck. And this is in that trigone area. And this is where those nerves are sitting that will trigger that, telling your brain when your bladder is full and you need to release. And so if everything is already like irritated and inflamed, then often you're getting false signals to your brain saying, hey, we need to go pee, we need to go pee, even though your bladder's not actually full. So the symptoms that you're going to get are that frequency, urgency, getting up more at night, but the stream is still good, a burning sensation with urination, you might see some blood or some incontinence. And a lot of these symptoms actually overlap, where it looks like same symptoms as a urinary tract infection. But just know, urinary tract infections, they're not common in males just due to their anatomy, but it's still usually a good idea to rule those out first. So just get a quick urine sample. The other bucket of symptoms are your obstructive symptoms. So think prostate, right? So the prostate itself is getting radiated and getting unhappy. And so you can get some swelling. And remember, from the anatomy, that urethra is running right through it and it's getting squeezed off. So that garden hose is getting clamped down. And so what you're going to see is like a weak stream. hesitancy. So the flow doesn't want to start right away. The flow is starting and stopping. You're straining, pushing to get it out. Bladder's not emptying all the way. The other thing is that they may say that they're having dysuria, but it's more of a discomfort rather than a burning sensation. And they might be having some increased frequency just due to the bladder not emptying all the way. The reason it's important to know what type of symptom they're having is because you're going to manage it a little bit differently. So with irritative symptoms, typically we will just start
Sarah,
with
can I
diet and behavior.
interject? Sorry.
Hmm.
Yeah. So
Yeah.
if you go back to the previous slide, so it is very important to distinguish between irritative and obstructive. And sometimes people have both. The symptoms
Right.
are good to get to base off of, but a lot of times it's hard to distinguish between the two just based off symptoms, to be honest. I find it's often useful to do a they call PVR, post-void residual. So essentially you get a ultrasound and measure their bladder volume after they pee, right? After they void, you measure the bladder. It should be like that's a very small amount of urine left over, let's say 50 cc's or less. But if somebody really have a like a 200 cc of bladder, that's probably pointing more towards obstructive symptoms. But if somebody has like a more like less than 100 PVR afterwards, sometimes it suggests irritative symptoms. It's not a black and white distinction, but I think the post-void residual definitely helps because, for example, the pharmacological intervention for obstructive and irritative is different. I'm sure Sarah probably will talk about that later as well. For example, oxybutynin or certain medications that relax the muscle of the bladder. If you have irritative, like overactive bladder, if overactive bladder is the culprit, then that medication will help. But if somebody is have peeing problem because their muscle of the bladder wall cannot contract, and if you give that medication, that's going to worsen the urinary retention. So you want to be really have a good idea what is going on before you prescribe, for example, medication to relax the bladder. Anyway, thanks.
Yeah. Okay. Before we get to the medication piece, yeah, let's talk about diet and behavior because like I said, this is a very quick, easy one to help manage their symptoms and something that nurses can easily do. Bladder irritants, these are the foods and drinks that already irritate the bladder, even if you're not undergoing radiation. So maybe they tolerated them fine. It's just that now you're adding insult to injury because the bladder is already irritated. So I tell guys, these are all the fun things in life. Okay. So things that make your irritative symptoms worse can be caffeine, alcohol, spicy foods, your tomatoes, so your pizzas, citrus, fizzy drinks, so soda, carbonated water, sugary drinks, dairy, and then smoking. So those are the big ones that they might want to look at cutting out. And again, this is based on how bothered they are by the symptoms they're having. Sometimes it's a good idea to keep a food journal and symptom list just to see if they can identify their particular triggers. And then the other thing is remind them they need to stay hydrated. A lot of these guys, as they start to have more frequency and urgency, they're like, you know what? I'm just not going to drink fluids because I'm tired of going bathroom all the time. And that backfires on them because the bladder does not love concentrated urine. It irritates the bladder. And so it just makes them have frequency anyways. So have them hydrate to the point where what they should be looking at their urine, and their urine should be like a pale yellow to almost clear. And that's a good indication of how hydrated you are. Another quick, easy behavior modification is if they're getting up a lot at night and that's bothering them, for easiest thing to do, stop fluids at least 2 hours before bedtime, and that can help. If those things don't work, then you move on to medications. So there are a lot of different things that you can do for irritative. We usually will start with NSAID. So these are medications like Advil, ibuprofen, those types of things. This is for inflammation, not pain. Okay. So you're trying to get that inflammation down around the bladder neck so everything just will calm down. Typically, you want them taking it on a schedule, right? So 2 to 3 times a day, anywhere from like 400 to 800 milligrams of ibuprofen, rather than just taking it as needed. Because if you can stay on top of the inflammation, it tends to work a little bit better. As a nurse, things that you need to make sure of, make sure they're not on blood thinners. Can't take NSAIDs when you're on blood thinners. And then be careful with kidney disease, those types of things. And then guys will ask, well, can I just take Tylenol? And it's like, you could, but it's probably not going to be super helpful, right? Because Tylenol does not have an anti-inflammatory properties. And so this is that medication, acetaminophen, or I forget what it's called, probably in Africa, paracetamol, I think it is. Another medication is pyridium. So active generic drug ingredient is phenazopyridine. This is great for that burning sensation or that dysuria, and that kind of comes with some urgency and frequency, and it helps with just numbing the bladder. Let guys know this is going to turn your urine a real funky orange looking color. So they might be caught off guard if they're not aware of that. The other thing is that if you have any suspicion for a urinary tract infection, you need to get a sample first, because once this medication is on board and the urine looks orange, it's going to be very hard to test. Oxybutynin that Dr. Ma mentioned, this is an antispasmodic. It works by relaxing the bladder muscles, and it's helped for that overactive bladder, that frequency, that urgency. But you really should be ruling out retention first, right? You don't want to give this to somebody who already has a history of retention and throw them into full-blown retention. And like you said, in our clinic, we often will just do a quick PVR to make sure that they're not retaining before starting them out on this medication. Let them know this medication tends to dry you out. So they should not be surprised if all of us, once they're on it, if they're having like dry mouth, dry eyes, dry skin, those types of things. And then the other thing is this one takes a little bit longer to kick in, where the other ones are fairly fast acting. Another medication we use, steroids, often we're using dexamethasone. This tends to be either as a last resort or for those who can't take those NSAIDs. Steroids need to be taken with food. They're a little bit harder on their stomach. Things that guys need to watch out for is this medication. I tell them it's like everything kind of is amped up, right? So increased energy can cause insomnia, increase your appetite, increase their blood sugars, those types of things. So they shouldn't take it too close to bed. Otherwise, they're going to have a hard time sleeping. And then if all else fails, right, you've done all of these and they're still absolutely miserable, then they may just need a treatment break. I will say that's not very common. Obstructive symptoms. So yeah, obstructive symptoms, again, think that prostate, think that flow issue. Diet is generally not super helpful with this class of symptoms, and you pretty much will need some type of medication. And the class of medications commonly used are alpha blockers. And these alpha blockers help by relaxing the smooth muscle of the prostate and that prostatic urethra and the bladder neck. So just open up that garden hose again. The one that you might be the most familiar with is tamsulosin. So this is a medication that you can take once or twice, 1 to 2 capsules a day, whether you take them together or morning and night. Things to know about this medication: very quick on, very quick off. Okay, so once they take their first 1 to 2 doses, they should get some relief. They should see a change in their symptom. Their stream should be opening up. They should be getting up less at night, that type of thing. The most common side effect, it can lower their blood pressure. So they need to be careful or look out for getting a little dizzy or lightheaded. And that means that they should not be, or so to change position slowly. I always tell guys, because they're commonly taking this in the evening. So when you get up at night to pee, don't jump out of bed and run to the bathroom, because it's usually by the time you get to the bathroom that you get really dizzy and lightheaded. And there are a lot of sharp objects in bathrooms to hit your head on as you go down. The other thing to be on the lookout for is look at their medication list. If they're on Viagra, Cialis, those types of medications, you got to warn them not to take them too close together, because they can both lower your blood pressure. Okay, next question. So this is a critical thinking question. So a 65-year-old gentleman who is status post-route, this means that they've had their prostate removed, is undergoing prostate bed or salvage radiation. He's on his 10th of 39 fractions of treatment, and now he's reporting that his urine stream is getting weaker. Is this an anticipated side effect? Yes or no?
This is a tricky question, Sarah. Yeah, I'm interested to see how the audience does.
Some 86% people said yes. 14% says no. Okay,
All
so
right, yeah. So this was a little bit of a trick question because the right answer is actually no. So again, when you think of flow issues, right? He's saying he has a weak stream, you should think prostate, right? This guy doesn't have a prostate, it's been removed. So there shouldn't be anything compressing on his urethra. And so if you have somebody with a prostate who doesn't have a prostate and they're having a weak stream, then you're going to ask them more about things like, do you have a history of urethral strictures, those types of things? Because are they having scar tissue in their urethra? That's the reason why they're having a weak flow, but it's not something that you would normally anticipate. Sorry for the trick question. Okay, let's talk about bowel side effects. So these are number 2, the second most common symptom from radiation treatment. This is due to an inflammatory process, right? So things to consider. Again, you want to know what their baseline is. That's always important. The Bristol chart, I love the Bristol chart. This is on my clipboard, and I just have the patient tell me, what does their normal stool look like? Not just are they going every day, but what does it look like? Are they more constipated, or they tend to be more loose stool? The other reason I like to use this is because often they'll report that they're having diarrhea, but it's really just they're really just having Bristol 5 or Bristol 6 because diarrhea is only a Bristol 7, right? This is where there's no solid pieces. Everything else is not true diarrhea. So it's important to know that specifically. So if they're having symptoms, again, you always want to know, is this a one-off or is this a pattern? Did they just eat something that really threw their gut off, or did they get a GI bug? Those types of things. Did they change their diet recently? Are they on any bowel meds? Oftentimes you might need to be pulling them off their laxatives or stool softeners if they were taking them at baseline. The other thing that you want to know is this actually overflow diarrhea? So you can ask the doc to take a look at the films to see, do they have like a little ball of stool that's stuck in their gut, and then you just have the liquid leaking out around it, because obviously that is a different treatment or different interventions than if it's true diarrhea. So remember, prostate radiation does not cause constipation. Okay, you should be looking for the opposite. Let's just skip this one and we'll just move on. Okay, so let's just talk about, how do we manage the loose stool or diarrhea? So again, first things, easy things to do is diet and behavior. And again, a lot of it is pulling out those things that irritate the gut. And actually, a lot of the things that irritate the gut are the same things that irritate that bladder, because you go back to those bladder irritants, caffeine, alcohol, artificial sweeteners, those types of things. The other thing that we do, we pull in our dietitian pretty quick. We love our dietitian to help. They can get into the absolute nuances of the diet. So that can be helpful. The other thing is that when they are having true diarrhea, you got to look out for dehydration. If they are losing a lot of fluids through their gut, oftentimes they're losing a lot of potassium, which is found in the gut. And so they need to be replenishing their fluids, but not just with water. They need to be replacing it with some type of electrolytes. The other thing is fiber. So they'll want to reduce their insoluble fiber and add in some soluble fiber. Let's talk about fibers. Fiber can be a little bit tricky. You have a couple of different types of fiber. So soluble, think about it's like a mop, right? It's soaking up the liquid, and then it's also, as it soaks it up, creates like this gel-like substance. So it works by slowing down the digestion. So this is great for diarrhea, right? So soak it up, slow it down. But it can also help with constipation because that gel-like substance is helping keep those stools soft. So a very common thing that you'll see is people are taking psyllium. I call psyllium the great regulator because it can help with both diarrhea and constipation. But in order to help with constipation, they need to be adequately hydrated, right? They need some fluids to actually be soaking up. Insoluble fiber, these are the types of things that are pretty high in like your vegan or your vegetarian diet. This doesn't get fully broken down or absorbed in water. And so it's actually what is the bulk of the stool, makes up the bulk of the stool. And then that bulk of the stool, it irritates the gut. So we call it like the sweeper of the colon. And so this can speed up digestion. So this can be great for constipation, but it's terrible for diarrhea. So these are the types of things that you're having them back off just when they're having diarrhea. So things like their whole grains, brown rice, nuts, potatoes with skins, your leafy vegetables, fruits with peels, those types of things. So they should avoid those. while they're having diarrhea. And then once that diarrhea has resolved, they can slowly reintroduce it. If diet and behavior modifications aren't working, then you can add on some bowel medications. So for your grade 1, which is the less than 4 stools above their baseline, you can add on some Pepto-Bismol or kaopectate to get things to slow down. Grade 2, which is 4 to 6 stools over baseline, then you're adding on loperamide or Lomotil. But to be honest, I'll say when it's true diarrhea, we're intervening pretty quickly just because it causes so many prep issues as well, that we will usually just go straight to loperamide to get things to slow down. Follow the package instructions. They can take up to 2 a day, and you're just getting them. They just need to titrate it so that their stools are like that Bristol 4. You don't want to overcorrect it and end up constipated. So it's usually a little bit of a titration game. So I put on here other less common bowel side effects. So some people will get tenesmus. So this is defined as that like persistent feeling to have a bowel movement, even though there might not be any stool there. It's a little bit tricky to treat. So oftentimes it's associated with like diarrhea, those types of things. So treat the underlying cause, add in some soluble fiber to help slow down the gut. That can help, or a little bit of Imodium. But again, you got to be careful with Imodium that you don't overcorrect and cause constipation. Rectal pain, if it's bad enough and they're really bothered, you can do some rectal steroids like Procticor or Proctiform. And then if they're having bleeding, the first thing to ask them, do you have a history of hemorrhoids? Is your stool really hard? The tissue down there is a little bit more fragile. And so if they're passing hard stools or have those hemorrhoids, that can cause a little bit of bleeding. And so your first thing that you want to do is to just try and get them so that they're not straining and that the stool is really soft. For kind of a little bit more than just scant bleeding, you might be doing sucralfate enemas or Procticor, and then if it's bad enough, they're going to need a treatment break. So fatigue is the one non-localized radiation side effect. Fatigue is common with all radiation. For prostate, it tends to be pretty mild, tends to be near the end of treatment. But if they're on hormone suppression or ADT, it's a double whammy. So they can be a little bit more tired by the end of treatment. I wish there were a magic pill for this. There's not. So the best thing that they can do is to stay active. So get some exercise. And fatigue is going to be covered much more in that last series in this lecture. So androgen deprivation therapy, let's talk about what that is. This is medication. It's typically an injection. There are other forms as well, but it's typically an injection that you're giving to either suppress the production or the usage of testosterone. So essentially, you're trying to shut down the testosterone factory in the body. And the reason that you want to do that is testosterone is what is feeding the prostate cancer. So if you starve it, then you can slow down or stop the growth of the prostate cancer. But remember, this is not a cure by itself. You can't just cure prostate cancer with hormone suppression. You still need to do a curative treatment. This medication can be used before, during, and or after treatment. If it's used during or before, if it started before treatment, oftentimes because it has arrested the growth of the cancer, it buys you time to get started. If for example, some of our guys need to go get heart surgery or they need to get their urine symptoms optimized before treatment, those types of things. The other thing to know is it can shrink the prostate. And so because that is happening, you want to wait to start radiation because you want that shrinkage to have happened and stabilized before you start, because you don't want the volume of the prostate to be shrinking on treatment and then the plan size has changed. So who gets hormone suppression? This goes back to that risk category. Typically, you don't need it until you get to that unfavorable intermediate risk, and then they just need a short course of 4 to 6 months. High risk category is a year or two. It depends on how old they are and how healthy they are, those types of things. Sometimes you'll see abiraterone added on. And then metastatic, they're usually on this lifelong or until the cancer gets smart enough to become resistant to this medication. And this is where you'll start to get into other medications and possibly chemo, which could be a whole lecture on its own. Side effects, I warn guys, like we do a full-on teach with guys before they start this medication of what to expect. And I think that as a nurse, helping them understand what's coming down the pipeline for them is really important because it helps them prepare for the side effects rather than being caught off guard. So all of their side effects are generally from a lack of testosterone, right? So if you see in the circles here, these are the different groups of side effects, with the three most common being hot flashes, erectile dysfunction, and lower libido and fatigue. And I would say this happens in more than 90% of the guys on this medication. These lesser common ones like loss of muscle mass, lower bone density, decreased testicle size, weight gain, mood, or cognitive changes is a little less common and directly related to how long they're on the medication. So the longer they're on it, the higher chance that this could happen. So once they're finished with hormone suppression, remind them it can take months or years to recover. You can't just flip a switch and turn that factory back on. So it can be a slow recovery and it may never fully get back to normal. There's a lot of factors that can play into that. Diet and exercise are extremely important in helping manage a lot of these side effects. And the other thing as a nurse is make sure you're doing a good symptom check with each injection because oftentimes they're just suffering in silence or they're ready to give up. And if you can help, there are a lot of things that they can do to help manage these side effects so that they're a little bit more compliant. Hot flashes is the one that I see as being the most bothersome to guys. So I always remind guys, if you ever know a woman who's gone through menopause and had hot flashes, this is the same thing, right? Feeling a little bit warm to full on sweating. It can come any time of day or at night. Tends to be worse at night for whatever reason for guys. Lots of different triggers, so everybody's a little bit different. Common ones are alcohol, stress, caffeine, even tight clothing, those types of things. I have to remind guys it's not just a feeling of hot. Sometimes they actually feel chilled instead. And then as their testosterone is recovering, those hot flashes can actually get a little worse as your body's recovering testosterone. So, what are some things that they can do? So, the big one is if they can figure out what's triggering it, then obviously just avoid those. Other thing, wear layers, right? Because you're hot and cold, you're hot and cold. Layers are coming off and on. It's very helpful if they can sleep in a cold room with a fan blowing on them. That can help with those night hot flashes. And then if they're just straight up miserable and ready to quit, then there are medications that they can be put on to help with the hot flashes. The one we most commonly use is venlafaxine or Effexor. So this is actually an antidepressant, but the off-label use is for hot flashes. And then other medications I've seen used are gabapentin or Megace. And I would say the other second most common complaint from hormone suppression is fatigue, right? So they're really tired. It doesn't matter how much they sleep, they're just tired. And like I said, there's a whole lecture that's going to be on fatigue. All right, so we'll get to post-treatment care. So this is those chronic side effects, and then how do they know that treatment is effective? So chronic side effects, typically once they've done radiation, you don't normally expect them to develop long-term complications. So those things that show up months to years down the road. They're pretty uncommon, but the ones that you're looking for, so erectile dysfunction, out of all of them, this is a little bit more common than anything else. And this is because if those micro vessels and the nerves that are down in the area end up like getting scar tissue or are damaged long term, and so they end up with erectile dysfunction. It doesn't happen overnight. It usually takes about 1 to 2 years to develop. And the rates that I found are all over, but it looks like roughly half of the men who go through external beam can develop erectile dysfunction, and the rate is a little bit lower than brachytherapy. But of course, there are huge risk factors, right? The older you are, the more chance of this happening. And a lot of guys already come into radiation with erectile dysfunction, and then radiation is not going to help it. It's not going to fix it. So it was already pre-existing. If they were on hormone suppression, that can increase the chance of developing erectile dysfunction long term. And then if they have a history of diabetes or vascular, again, that's all impacting the vessels in that area. Things that you can do, this is really just medical management. The doctors are often starting with some PDE inhibitors, PDE5 inhibitors like Viagra or Cialis. And some of the urologists are starting to give them like a small dose daily to help keep the blood flow going down to that region. And then with an additional dose of as needed. I always tell them, go talk to your urologist early if this is a concern for you. Urinary complications, again, not super common, but the one that will pop up here and there is cystitis. And so this is like all of a sudden they're having a return of those obstructive or irritative symptoms or blood in their urine. So I always tell guys, blood in your urine is never normal. Okay. The chance of this happening tends to be higher if they already came into treatment with not great urinary function to begin with. The other thing that can happen are strictures. So this is the scar tissue being built up in the urethra, and then they're getting like a weak stream and having to push a strain, and Flomax is not helping, right? So Flomax isn't helping, then you should start to think of whether they have a stricture. Not a lot for nurses to do in these types of situations. Like you can manage the obstructive or irritative symptoms similar, but if for strictures or long-term complications, you typically need to send them to urology because they have all the equipment to do scopes and those types of things to see what's really going on. The one thing I'd say for nurses is it's pretty quick and easy to do a urinalysis to look for an infection or bleeding. And then for proctitis, so again, this is not super common, but maybe a little bit more common for those who got more than 60 gray to the rectum. So just a reminder that a common dose of radiation to the prostate is about 70 to 79 gray. So how tight you got that plan to the prostate will determine how much the rectum received. Proctitis is defined as the inflammation of the rectal lining. It's actually not inflammation. This is more like scar tissue, so vascular sclerosis and fibrosis. Things that they may report that you're looking out for is rectal pain, okay? Bleeding tends to be the most common. If they're having proctitis, that's the most common symptom. And then that tenesmus or urgency, maybe their stool is becoming a little bit more thin, or all of a sudden they're developing persistent diarrhea or constipation. Things that you can do as a nurse. So for diarrhea, constipation, the same interventions that you were using during treatment. If they're having bleeding, make sure they're not anemic, okay? And then also if they're having any bleeding, make sure they're not on blood thinners, aspirins, or NSAIDs, those types of things. Commonly, they're going to need an endoscopy, so it's like a colonoscopy. Things that you want to remind the guys is that they need to let whoever's doing their colonoscopy know not to biopsy the scar tissue in the rectum from radiation because there's a risk of developing a fistula. So they should avoid it if at all possible, unless there's a huge clinical concern. This is a little bit of a busy slide. It talks about medical management for proctitis. We won't go into detail, but just so you're aware of what you might end up seeing. You might see the doctors prescribing those rectal steroids, okay, proctofoam. You might see a sucralc enema if they're having some bleeding. And then if those don't work, then often argon plasma coagulation can be an option. All right, last poll question, if this one works. How many of your prostate cancer patients experience rectal bleeding after treatment?
Sounds right now everybody's
good.
answering A.
Oh,
there.
yay. I'm happy to hear that.
Maybe a couple
Good.
B, but like mostly A.
Yeah.
Yeah.
Good. Okay, great. All right. So the big takeaway with chronic side effects. So tell guys that once they've established their new baseline of their bowel and bladder habits, somewhere around 6 months or so after radiation, if they have a significant change from that in how they're peeing and pooping, and there's no explanation, right? Meaning that they don't have a urinary tract infection, they didn't eat something and have bad diarrhea for a couple days, those types of things, right? If there's no explanation and it lasts longer than 2 weeks, then they should not ignore it. They need to, whether it's calling you or calling their primary, they need to get that looked at. Okay. All right. Last section. We're almost done. How do we know treatment worked? So it's all about the PSA. So they're going to be getting their PSA typically about every 6 months for the first 5 years, and then yearly from there on out. It can take up to 2 years from radiation alone for it to nadir or to get it as low as it's going to get. And then it should just stay right around there. And as long as it's staying around there, you just do a PSA. You don't need to do anything else. They typically won't do any imaging or anything like that until their PSA starts to creep up. And I think the definition for recurrence is called the Phoenix criteria, so 2 over nadir. And then at that point, that's where they're going to maybe do some imaging and start looking for where that PSA is coming from. But otherwise, like I said, it's just a PSA. So things to remind them when they're getting their PSAs. 48 hours prior to getting that PSA, you don't want to do anything that is stimulating that prostate, right? Vigorous exercise, straddling exercises like biking, no ejaculation, because those can all just temporarily increase the PSA. And urinary symptoms, if for some reason they're having a flare of urinary symptoms, just wait to test their PSA until after that's resolved. Okay. Recurrence is almost always found by rising PSA rather than symptoms. So just remind them once they're done, get their PSAs checked regularly. So just quick take home point. So I hope that my point is helping understand the why is going to really help you understand how to care for a patient. Minimizing side effects starts before radiation even begins. And that's by choosing the right fractionation, the best modality, and getting that prep. You're going to be managing a lot of bowel and bladder symptoms during treatment, but those should resolve within the months after finishing, and that you will play an important role in helping your patients get through their treatment. So these are the references and some good resources for you to check out. And that's all I have. Thank you very much.